This is another case of a baseline screening mammogram. This is in the patient's left breast. There were calcifications that were noted in the upper outer quadrant. This was given a BI-RADS 0, so we could do additional views to determine the morphology of this finding. So when we have calcifications, we get these special views called magnification views. We do a true lateral and a craniocaudal magnification view to allow us to see the morphology of the finding. And here we see those calcifications. They might be a little bit subtle on the monitor, but they are little dots, little white dots that we're seeing here. And each of the dots looks similar to the other ones. I would describe this morphology as being punctate or round calcifications. It's important to also note how large of an area the calcifications span. So this spans a little bit over a centimeter. When I'm looking at the calcifications, I want to, like I said, first note at what the individual calcifications look like compared to the other ones. Do they all look the same or do they look different from each other? And like I said, I think these all look like little dots. So if they look different from each other, then I would be thinking about pleomorphic calcifications or heterogeneous calcifications, which are more suspicious descriptors. When they look like small dots, I can call them punctate or round calcifications. I also want to look at how the calcifications look on the two different views. So on the left is our lateral view, and on the right is our CC view. And I want to see if they look similar on the two views, or if they look like they're layering on the lateral view. This layering is a common benign finding that we'll see. And if the calcifications look like they're layering, we can give this a BI-RADS 2. These really look similar on the two views. And they are spanning about a centimeter, a little over a centimeter, so the distribution would be grouped. These are grouped round or punctate calcifications that we saw on a baseline screening mammogram. This is the second good indication for a BI-RADS 3. So this was given a BI-RADS 3. We had the patient follow up, recommended for 6 months, 12 months, and 2 years. This is the 2-year follow-up CC view. And we see those calcifications again. Can zoom in, so they're kind of looking at the same size, but we saw no significant changes in our 2 years of follow-up. So after the 2 years of follow-up, we were able to give this a BI-RADS 2 and have the patient then return to screening.
Hi, I am Emily Anbinder. I'm an assistant professor in radiology and oncology at Johns Hopkins, and I'm really excited to be here today to talk about BI-RADS 3 in multimodality breast imaging. Now, BI-RADS 3 is a really challenging topic for breast imagers, and I'm hoping that this talk will help to clarify things and make it a topic that you don't dislike as much as you might at the beginning of the talk. So I just want to start by talking about the BI-RADS Atlas. Now, this is something that I love about breast radiology. This is a lexicon that breast radiologists use to describe findings on mammogram, ultrasound, and MRI. And with it, any breast imaging study should be reported the same way, regardless of which breast radiology is looking at it. Every breast imaging report is given an assessment category. And I know this will probably be a review, but I just want to set the stage for the BI-RADS 3 category before we get into more details on it. And with each of these categories comes a recommendation for what the patient should do to follow up. So the first two I just want to mention are BI-RADS categories 1 or 2, and that's when the study is either negative or benign. And when we use those terms, the breast radiologist is indicating that there is a 0% chance that there is a cancer in that study, and we're recommending a follow-up in 1 year. Now, on the flip side, when we use the BI-RADS terms 4 or 5, we're saying that we see something on the breast imaging study that is suspicious and will recommend a biopsy. Within this 4 or 5 categories, we have subcategories. So 4A indicates a 2 to 10% chance of malignancy, 4B up to 50%, 4C up to 95%. And when we use a category 5, we're saying that we're very suspicious. We believe that there's over a 95% chance that the finding represents a cancer. Regardless, with any of those BI-RADS assessment scores, we'll be recommending a biopsy to get a tissue diagnosis. A BI-RADS 6 means that there is a biopsy proven malignancy on the imaging. A BI-RADS assessment category 0 means that the study is inconclusive and we need to do additional diagnostic workup. And finally is our favorite category, BI-RADS 3. And we use this term probably benign, meaning that there's greater than a 0% chance of cancer. So it doesn't fall into that BI-RADS 1 or 2 categories, but there's a very small chance of cancer, less than or equal to 2%. So we doesn't reach our threshold to recommend a biopsy, and we'll do a follow-up in 6 months. So BI-RADS 3, this probably benign. This is just it's a really challenging topic, and that's what we're going to be focusing on during this talk. Like I said, this means that there is a low chance of malignancy. It's not 0%, but it's very small, less than or equal to 2%. So it doesn't reach our threshold to be recommending a biopsy, but we do want to keep a close eye on the finding because we know there's at least a small chance that it could represent a cancer. When we give something a BI-RADS 3 assessment, we recommend having surveillance imaging at 6 months after their initial study. So that would be halfway in between a normal screening schedule. That would be an extra appointment. Then they would come back at 12 months. So that should be the time that usually that patient would be coming for their screening mammogram. Instead, they would be coming in for a diagnostic appointment to follow up this finding. And then at 24 months. Similarly, that should be at the time that they would be coming in anyway for their annual imaging. There is an optional follow-up at 36 months. We should only use the BI-RADS 3 category after we've done a full diagnostic workup. And that's really for 2 separate reasons. So first is we want to limit unnecessary follow-ups for findings that could have been assessed as benign. And I'm going to show some examples of that. Something that may have met BI-RADS 3 criteria on mammogram, but then when we do an ultrasound, we see that it's clearly a benign finding, such as a simple cyst. We also want to make sure we're not delaying diagnosis of small cancers that could have been diagnosed with a full diagnostic workup. So we never give a BI-RADS 3 assessment directly from a screening exam. We always want to bring that patient back, do a full diagnostic workup before using this category. I want to stress that BI-RADS 3 is not just an intermediate category that we should use when we're unsure what to do. I think this is tempting when we're seeing a patient and it's maybe a confusing case and we think, well, let's just give it a BI-RADS 3 because we're not sure. And that's not how we should be using BI-RADS 3. BI-RADS 3 should really be reserved for specific findings that we know with evidence-based data have a low chance of malignancy. And we're going to go over these today to help show what those findings are and go over some of the data that supports the use of BI-RADS 3 for these cases. The benefit of using BI-RADS 3 is to reduce the number of benign biopsies performed while maintaining a high sensitivity for early stage breast cancer. So when we're thinking about using BI-RADS 3, we really want to think that we're using it to remove cases that might have been recommended for biopsy because they have a very, very low chance of malignancy, less than that 2% number. We don't want to be using it for cases instead of giving something a BI-RADS 2 that could be safely assessed as being benign. We really want to be finding these very specific imaging findings that have a low likelihood of malignancy to give this assessment. I want to just note that there are definitely challenges with BI-RADS 3, and I think anybody who's done any breast imaging can relate to this. The 2 main ones are first that there's quite a high inter-observer variability with using BI-RADS 3, and I'm hoping that this talk will help to maybe decrease that among the people that are watching, because We really should only be using it for specific imaging findings, but there's been several studies showing that even among breast radiologists, there's a lot of variability in how BI-RADS 3 is used. Second is that we're asking patients to come back for this extra appointment when they wouldn't have needed to come back for breast imaging if we had given something a BI-RADS 1 or 2, this 6-month appointment. And we found that there's very low compliance with that BI-RADS 3 recommendation. That's another day that that woman is going to have to take off work or find childcare. There's a cost associated with an extra appointment. And I think we should kind of keep that in mind when we're making this recommendation and make sure we're really using it when it's appropriate. And, when it's appropriate, we do want to be using it to make sure that we're catching the few of those cases that are actually cancers. But we don't want to be overusing it because we know that there's a challenge with having patients come back for this extra appointment.
This is our first case. This is a baseline screening mammogram on a 40-year-old woman in her right breast in the lower central breast at middle depth. You notice this finding. This is a 2-view finding. It doesn't meet BI-RADS description for a mass, so we would describe this as a focal asymmetry. This was given a BI-RADS 0 from her screening mammogram. I am going to show it on the tomo so you can see how it looks here. So with tomo, we're able to scroll through the finding, and this is particularly helpful with asymmetries and focal asymmetries to determine whether the finding represents overlapping breast tissue or a true finding. And as you can see, as I scroll through the finding, it does seem present on a single slice rather than overlapping fibroglandular tissue where it sort of spreads out on multiple slices. But as you can see in this slice here, I see that finding. Similarly on the MLO view, when I scroll through the MLO view, I can see this finding in the lower breast that stands out. So this was given a BI-RADS 0 when we had the patient come back for additional imaging. Specifically, we do spot compression views, and that's to determine whether the finding persists when we are compressing that area of the breast. So here are the spot compression CC and MLO views. And again, we see that finding here in the central lower breast, which is persisting on the spot compression views. An ultrasound was also done and there was not a sonographic correlate identified. This is a good indication for a BI-RADS 3 on mammogram. This is a focal asymmetry on a baseline mammogram without a sonographic correlate. This patient was recommended to come back in 6 months. So we had follow-ups at 6 months, at 12 months, and 24 months, as I talked about before. Again, this was the baseline screen. And this was her 2-year follow-up exam. And we see that focal asymmetry looks identical. In the MLO view also, we see that finding here. And then on the 2-year follow-up, we see stability. After this finding was stable for 2 years, we were able to conclude that this was a benign finding and change the exam to a BI-RADS 2. Okay, this is another case of a baseline screening mammogram. This is in the patient's left breast. There were calcifications that were noted in the upper outer quadrant. This was given a BI-RADS 0 so we could do additional views to determine the morphology of this finding. So when we have calcifications, we get these special views called magnification views. We do a true lateral and a craniocaudal magnification view to allow us to see the morphology of the finding. And here we see those calcifications. They might be a little bit subtle on the monitor, but they are little dots, little white dots that we're seeing here. And each of the dots looks similar to the other ones. I would describe this morphology as being punctate or round calcifications. It's important to also note how large of an area the calcifications span. So this spans a little bit over a centimeter. When I'm looking at the calcifications, I want to, like I said, first note at what the individual calcifications look like compared to the other ones. Do they all look the same or do they look different from each other? And like I said, I think these all look like little dots. So if they look different from each other, then I would be thinking about pleomorphic calcifications or heterogeneous calcifications, which are more suspicious descriptors. When they look like small dots, I can call them punctate or round calcifications. I also want to look at how the calcifications look on the two different views. So on the left is our lateral view, and on the right is our CC view. And I want to see if they look similar on the two views, or if they look like they're layering on the lateral view. This layering is a common benign finding that we'll see. And if the calcifications look like they're layering, we can give this a BI-RADS 2. These really look similar on the two views. And they are spanning about a centimeter, a little over a centimeter, so the distribution would be grouped. These are grouped round or punctate calcifications that we saw on a baseline screening mammogram. This is the second good indication for a BI-RADS 3. So this was given a BI-RADS 3. We had the patient follow up recommended for 6 months, 12 months, and 2 years. This is the 2-year follow-up CC view. And we see those calcifications again. You can zoom in, so they're kind of looking at them at the same size, but we saw no significant changes in our 2 years of follow-up. So after the 2 years of follow-up, we were able to give this a BI-RADS 2 and have the patient then return to screening.
Here's another patient that was recalled from a baseline screening mammogram for calcifications. And my left image is the callback mammogram magnification CC view. And I know the images are definitely harder to see on probably your home computer than if you were using a breast imaging monitor, but hopefully you can see this group of round and punctate calcifications in the outer breast here. And this was on a baseline exam. There was just an isolated group. The morphology on this magnification view is round and punctate. So this was appropriately given a BI-RADS 3 assessment, and the patient came back in 6 months. So my image on the right is the same magnification CC view at the 6-month follow-up appointment. And the calcifications, again, I think it's a little hard to see them, but hopefully they are projecting okay on your monitors. But they have increased in number, and they have a more amorphous look than what they did on their prior exam. So given this change on the 6-month follow-up, they were recommended for biopsy. And the biopsy resulted in flat epithelial atypia and atypical lobular hyperplasia. So that's a high-risk lesion. It was recommended for surgical excision. These were excised, and there was no malignancy on the surgical biopsy, and the atypia was completely removed. So this is when we're doing the 6-month follow-up. This is an example of a change that would cause us to change our recommendation from a BI-RADS 3 to a BI-RADS 4, because amorphous grouped calcifications no longer fit into that BI-RADS 3 category. And so the radiologist appropriately recommended biopsy, and we were able to diagnose this atypia.
Okay, these are images from another baseline screening mammogram. You'll see that this is really a theme of BI-RADS 3, is that we're really wanting BI-RADS 3 to almost always be on baseline exams. This is a 44-year-old woman coming in for her first baseline screening mammogram, and we saw this mass in the upper outer right breast. When the patient comes back for additional imaging, we start with spot compression views to better evaluate that finding. So here's the CC spot view. This is the C view. And again, we see this finding. It's in the upper breast. And let me just show you the tomo here. We see this is on the CC view, but it looks like a circumscribed mass. It's a single mass. She doesn't have multiple masses in both breasts. And on the MLO view, we see the finding here. And we scroll through it on the tomosynthesis slices, which really gives us a much better view of the margin. We see here, this is an oval mass with circumscribed margins. We would then recommend doing an ultrasound. If we did not have an ultrasound correlate for this finding, this would be the third indication for a BI-RADS 3 on mammogram, and that's a oval circumscribed mass on a baseline exam. However, we always want to do a targeted ultrasound to see if we can, instead of giving this a BI-RADS 3 and having that patient come back for those follow-up exams at 6 months, 12 months, and 24 months, if instead we can clear this patient and say that actually this is a benign finding. In this case, we did a targeted ultrasound. We see this in the right breast, 11 o'clock position, 5 centimeters from the nipple. So that matches the location of this finding in the upper outer right breast that we saw on mammogram. And here we see this simple cyst. So that oval circumscribed mass on mammogram may have met criteria for a BI-RADS 3, but we know that since it correlates to this benign finding on ultrasound, we can give this a BI-RADS 2 instead. The BI-RADS Atlas describes those 3 specific findings on mammogram and 3 specific findings on ultrasound, which they say are appropriate to give a BI-RADS 3 assessment based on evidence-based studies. But they also state that radiologists can use the BI-RADS 3 category based on their own experience. And one example of this is post-trauma. And this is when a patient comes in and has a good history of trauma. Maybe they had a car accident or they hit this area of their breast and they're coming in with a finding that you think is consistent with trauma, but aren't able to conclude with 100% certainty. Here's an example of that. This patient came in after having a car accident and now feeling a new lump in her right breast. And you can see this triangular shaped marker overlying the inner upper breast, which indicates that this is the area of palpable concern. And we see this kind of focal, maybe bordering on global asymmetry in the upper inner right breast, directly underlying that triangular shaped marker. So it's sort of this whole area here that's standing out. And this was a change from prior exams, but given her history and the fact that this is where she's feeling this area, and this was the area where she hit during her car accident, this probably falls into that category based on radiologist experience to give a BI-RADS 3. The BI-RADS Atlas suggests having the patients come back in 1 month, but there's been more recent data to suggest that 1 month is probably not long enough to allow that finding to change in a way to give a final assessment to determine whether it's suspicious or not. So our group typically uses 3 months, and there's several other groups and there's other expert recommendation to use more of 3 months to follow up trauma to give that finding enough time to declare itself. So here's our baseline. This is our exam that we give a BI-RADS 3 to, and this is when they came in 3 months later. And now you can see that area that we were worried about, we're seeing all of these new calcifications. I'm just going to zoom in on them so you can see them a little bit better here. This is a very classic appearance of fat necrosis. You can see these kind of curvilinear densities. Looks like they're kind of outlining circles of fat, and this is a typical appearance of fat necrosis, which is a benign mammographic finding. I just want to show you the MLO views as well. So here's our initial MLO view, and then our follow-up MLO view. And let's zoom in on that finding again. And you can see here these kind of curvilinear calcifications that seem to kind of border on areas of fat. This looks very typical for fat necrosis. So at this 3-month follow-up, we feel confident that these changes we saw in the breast are due to the car accident that the patient had, and we can now give this finding a BI-RADS 2.
Now that we've seen some really great examples of BI-RADS 3 on mammography, I just want to summarize what we've talked about and go over some of the data that supports these indications. So the first indication is a non-calcified round or oval circumscribed solid mass that has not been shown to be stable for at least 2 years. As we showed, those spot compression views can be really helpful to disperse adjacent fibroglandular tissue so that we can visualize the margins. We really want to be sure that the margin is circumscribed, and those spot compression views are very helpful for this. When we see a circumscribed mass on mammography, we will do a targeted ultrasound, and that's helpful because sometimes these masses represent a simple cyst or another benign etiology that we would be able to assess as a BI-RADS 2. So we really want to reserve the BI-RADS 3 for findings that don't have a definite benign sonographic correlate. The next finding is a focal asymmetry, and there's strong data in the literature that there's between a 0.5 and 1% likelihood of malignancy for a solitary focal asymmetry identified at screening. So just a few things to note are that it has to meet criteria for a focal asymmetry, and that means that it should be a 2-view finding occupying less than 1/4 of the breast, and there should be a full diagnostic evaluation. So we want to make sure we're doing spot compression views and not giving this assessment right from a screening mammogram. It's important that the asymmetry is not associated with any distortion, microcalcifications, or a mass. We want to make sure we're differentiating what a stable focal asymmetry. So if we have prior exams and we know that asymmetry has been present for greater than 2 years, that has a malignancy rate of 0%. That would just be considered part of that patient's normal fibroglandular tissue versus a developing asymmetry. And that's a new or increasing 2-view asymmetry. And it's been shown that even without an ultrasound correlate, a developing asymmetry can have a malignancy rate up to 20%. So a developing asymmetry really should be given a BI-RADS 4. So when we talk about BI-RADS 3 for a focal asymmetry, we're talking about a focal asymmetry seen on a baseline screening mammogram. And we know that that has a very low but non-zero chance of a malignancy. The final indication is an isolated group of punctate calcifications when we don't have prior examinations available. And like I've shown, we need to have magnification views before making the final assessment because those allow us to really see the morphology and the distribution of the calcifications. The BI-RADS 3 category should only be used for punctate calcifications, and we want to differentiate punctate from either round or amorphous calcifications. So punctate are very small, less than 0.5 millimeters in size. Round calcifications are larger than 0.5 millimeters, and usually those can be assessed as benign. I think in practice, we often will see mixed round and punctate calcifications, and we can consider that a BI-RADS 3. But if they're all larger than 0.5 millimeters, then those can be assessed as benign. Now, amorphous calcifications are when they have a fuzzy or smudgy appearance, and those should be assessed as suspicious. And the magnification views are very important at differentiating the round punctate morphology, which are probably benign or benign, from amorphous, which are suspicious and should be biopsied. We also want to make sure we're evaluating really carefully the distribution of the calcifications and making sure that the finding we're giving a BI-RADS 3 is really an isolated group. If they are in a diffuse pattern or there are multiple groups all over the breast, then we can assess those calcifications as benign. If they are in a linear or a segmental distribution, then we want to assess them as suspicious in biopsy. Now, the BI-RADS Atlas gives a few other examples of findings on mammography that may be appropriate for a BI-RADS 3 based on radiologist discretion. There's not strong data to support these. The first is calcifications thought to be developing fat necrosis, and we showed an example of that. Second is calcifications that are thought to be vascular. On the full diagnostic workup, you think they're probably vascular, but you can't tell with 100% certainty. Hopefully in 6 months that will declare itself and you'd be able to better determine that those are for sure vascular calcifications and not linear suspicious calcifications. The third one is an asymmetry or a distortion that's thought to be a post-surgical scar. I know in our group, we do this very infrequently. We try to use scar markers and really try to determine at the time of the diagnostic workup whether this is related to a prior surgery. And if we can't do that with confidence, then we would want to do a biopsy because we know, especially distortion has a high chance of malignancy. But the BI-RADS Atlas does say if you think it's probably post-surgical scar, but without 100% certainty, that might be a reasonable BI-RADS 3 indication. And then finally, we talk a lot about these being on a baseline exam or one where we don't have 2 years of stability. And there are some cases where it's hard to determine stability given differences in technique between studies. Sometimes this is just patient positioning between studies. Maybe a patient has lost weight, has had an interval surgery like a breast reduction. It's really hard to tell if something is new or stable. Another example would be when this is a first study with digital breast tomosynthesis. So if all of the priors were 2D mammograms, this is kind of like a new baseline and a finding may look different. And that could be a reason to put something into a BI-RADS 3 category that you might otherwise want to biopsy. And just talking about, I mentioned digital breast tomosynthesis, and I think it's relevant to just spend a minute on it when we're talking about BI-RADS 3. So digital breast tomosynthesis is kind of known as 3D mammography. It's actually reconstructed images that allows us to scroll through slices of the breast. And this has been shown in numerous studies to decrease our recall rates and increase our cancer detection rates. There's also been some studies showing that digital breast tomosynthesis leads to a decreased BI-RADS 3 rate. And that's mainly due to being able to assess focal asymmetries as overlapping fibroglandular tissue when we're scrolling through the tomosynthesis images and able to put a lot of those focal asymmetries into a BI-RADS 2 category and overall decrease our BI-RADS 3 rates.
This is a companion case to the last case, another baseline screening mammogram, woman age 40. And similar to the last case, we saw an oval mass. This is in the upper outer left breast. So also like the last case, this was given a BI-RADS 0. We had the patient come back for additional images, specifically spot compression images. And again, we see that mass in the outer breast on the CC view. And we see it here on the tomosynthesis. Like the last case, this would meet criteria for a BI-RADS 3 on mammogram. We see an oval circumscribed mass on a baseline mammogram. We're going to do a targeted ultrasound examination to see if we can potentially give this a BI-RADS 2 instead. And in this case, we did a targeted ultrasound. Again, this was the outer breast, slightly upper breast. So this is the 230 position, 4 centimeters from the nipple that matches the location. And we see this oval circumscribed mass, but this is a very typical appearance of a benign finding of an intramammary lymph node. See, most of the finding has this echogenicity that matches the surrounding fat. We see vascularity within that fatty hilum, a very thin hypoechoic cortex. This is a common finding in intramammary lymph node. We know this is a benign finding, and therefore we can give this entire case a BI-RADS 2 rather than a BI-RADS 3. Okay, so this is another companion case and also a good case to transition to our next section. This is another baseline screening mammogram. And this patient has an oval circumscribed mass in the upper outer right breast, which we see here. Again, like the last few cases, this was given a BI-RADS 0. She came back for additional mammographic images, and those are usually the spot compression images. This finding persisted on the spot compression images, and so we did a targeted ultrasound. Here's the images from the targeted ultrasound. We see this oval circumscribed mass. Now, this is not a simple cyst like we saw previously, and it's also not an intramammary lymph node, which we also saw previously. This looks like it's probably solid. It doesn't have typical appearance of a complicated cyst. For example, we don't see through transmission or an echogenic back wall. This finding meets criteria for a BI-RADS 3 on ultrasound. BI-RADS 3 on ultrasound, the first finding that we'll talk about is an oval circumscribed mass, so similar to the mammographic finding. So this finding actually meets criteria for BI-RADS 3 on both mammogram and ultrasound. Because this finding correlates, this is the same finding on the two modalities, we can just do ultrasound to follow it, so we don't have to expose the patient to extra radiation, even though it meets criteria on both modalities. So an oval circumscribed mass is also an appropriate BI-RADS 3 finding on ultrasound exam.
So this is another case of an oval circumscribed mass. This was a callback from a screening mammogram, and we saw this oval circumscribed mass measured up to 1.2 centimeters. And this was appropriately given a BI-RADS 3 with a recommendation for a 6-month follow-up. So when the patient came back in 6 months, we saw that the mass increased in size. So initially it measured up to 1.2 centimeters. And at the 6-month follow-up, it measured 1.8 by 1.2 by 2.3 centimeters. This was a greater than 20% increase in size over that 6 months. So when we see that increase in size, we want to do a biopsy. We wonder, could this be a fast-growing cancer? Could this be a phyllodes tumor? So this was recommended for biopsy and subsequently underwent an ultrasound guided biopsy, and the pathology showed a cellular fibroepithelial lesion suspicious for a phyllodes and is recommended for an excision. This is a great example of showing why we're doing that 6-month follow-up. So we caught this mass as it was growing. It did have an opportunity to grow, but it's still a small mass and would still be something that is easy to remove.
Okay, and this is if you have another baseline screening mammogram and another oval circumscribed mass, and this is in the central right breast. You can see here. And again, we have the patient come back for those spot compression images, and we see that finding persists here. This is on the CC view. So then we do a targeted ultrasound exam. And in this case, on the ultrasound, this is what we're seeing. This is a great example of clustered microcysts, which is the second indication for BI-RADS 3 on ultrasound that BI-RADS specifically describes. It's important to differentiate clustered microcysts like we're seeing here to simple cysts that are next to each other. But here we're seeing very small cystic spaces with septations throughout it. And this on a baseline mammogram would be an appropriate BI-RADS 3. We'd want to have the patient come back in 6 months to make sure that this is not changing. This is a targeted ultrasound of the left breast. It was for pain, but this was an incidental finding that was seen in that general area of pain, but didn't correlate with the exact site of pain. We see this is an oval circumscribed mass, but we see through transmission, which makes us think that this is probably a cyst, but it has some echogenicity in it. It's not a simple cyst like I showed before, where we felt confident that we could just give it a BI-RADS 2. Instead, we describe this as a complicated cyst. It's important to make sure that there's no solid component. If there's a portion of it that's solid, that would be described as a complex cystic and solid mass, and which should be given a BI-RADS 4. but this is a complicated cyst, so we would want to give a BI-RADS 3 and follow it. This patient came back for follow-up, and even though this finding got bigger, it still meets that complicated cyst description. We're seeing through transmission, it has a circumscribed wall. It's okay for them to change in size. Cysts tend to be hormonally sensitive. So this has changed in size, but it's still a BI-RADS 3 and should be continued to be followed.
Here's another example of a complicated cyst. This was a callback from a screening mammogram, and there was a focal asymmetry on mammogram. And then in the upper outer left breast at 2 o'clock, 12 centimeters from the nipple, we see this complicated cyst, and was it given a BI-RADS 3 with recommendation for a 6-month follow-up. We also saw at the same location a morphologically normal intramammary lymph node. So you can see that here. So there were 2 findings at the same location, an intramammary lymph node and a complicated cyst. Now the intramammary lymph node was given a BI-RADS 2 and the complicated cyst was given a BI-RADS 3. So the patient came back 6 months later and we did an ultrasound exam at that same location, left breast, 2 o'clock, 12 centimeters from the nipple. We see that morphologically normal intramammary lymph node again, but that complicated cyst is no longer there. So the cyst has completely resolved. That is very reassuring. We're able to switch this study to a BI-RADS 2 with a resolution of that BI-RADS 3 finding. This was a screening mammogram that was performed on a patient who had had a COVID-19 vaccine 1 week previously. The vaccine was done in the right arm, and on her MLO view, we noticed that there was what looked like an enlarged lymph node that's partially visualized up here in the right axilla. So the patient was given a BI-RADS 0 and recommended to come back for a diagnostic ultrasound exam. These are the images from the ultrasound. So we do see this lymph node, which has some cortical thickening measuring up to 4 millimeters. Now, 3 millimeters is typically our cutoff for a lymph node. Because this was so soon after her COVID-19 vaccine, we followed the SBI recommendation and recommended for her to come back for a short-term follow-up to see if this resolved. When she came back, this was right at 12 weeks after her second vaccine. So we would expect the vaccine-related adenopathy to resolve. We actually saw that the lymph node had gotten a little bit bigger. So now that, again, we see the cortical thickening measuring up to 5 or 6 millimeters, and it looks like there's actually some eccentric cortical thickening here. So this was then recommended for a biopsy, and the patient was diagnosed with CLL. This is unusual to have unilateral adenopathy with CLL, but it can happen, and this is a reason that we want to make sure we're following these patients to resolution of adenopathy, even when we think it's possibly related to the timing of a COVID vaccine. So this was a patient who was recalled from screening mammogram for axillary adenopathy. We did see some cortical thickening on her follow-up. We thought because of the timing so close to her COVID vaccine, it was likely reactive, did not resolve at the 12-week follow-up appointment, and biopsy did show CLL. So this is just a good reminder, and this is a new topic and may be evolving, but this is what the current guidelines are recommending that we do.
This is a companion case, but this is sort of the ultrasound companion. This is a patient who had had bilateral breast reduction and came in with a palpable area of concern in the right breast. And the image to the left is what we saw initially. This was an echogenic oval mass with circumscribed margins. And it measured just over 2 centimeters, 2.1 centimeters by, it's 2.1 by 0.8 by 2.4 centimeters. This was right in the area where she had had her reduction. It has this echogenic appearance that looks like it's probably fat necrosis, but it was palpable. We recommended to do a short-term follow-up, a 3-month follow-up to see how this finding evolved over time rather than doing a biopsy. On the right is her 3-month follow-up exam. And you can see that this finding has decreased in size pretty significantly. Now it measures 1.4 by 0.8 by 2.1 centimeters. This is quite a bit smaller in size. And we know cancer doesn't decrease in size, but fat necrosis will decrease in size over time. So given this change over time where it's decreasing in size, I feel confident that this is a benign finding and we're able to change it at that follow-up appointment from a BI-RADS 3 to a BI-RADS 2.
So those were some really good examples of good indications for BI-RADS 3 on ultrasound. And now I just want to go through those in a little bit more detail to emphasize what we were just looking at. So our first indication for BI-RADS 3 on ultrasound is a circumscribed oval solid parallel hypoechoic mass. And this has robust data. Most of these represent fibroadenomas, and we can safely call them a BI-RADS 3 and follow for 2 years. Now, when the lesion is palpable, there's really only good data for women under age 40. So if it's a palpable mass in a woman over age 40, it actually doesn't really fall into this BI-RADS 3 category, and we would recommend biopsy. You know, as any finding in BI-RADS 3, we want to make sure we're assessing it at the 6-month period to look for changes, and that's especially true for masses. And one of the main things we're looking at for these is a change in size. So if a mass decreases in size, we're going to feel really confident that it's not a cancer, and we could change that BI-RADS 3 to a BI-RADS 2. However, if it increases in size, and when we say increase, we use a 20% cutoff at 6 months, then we're going to want to do a biopsy. And we showed one case of that where a mass increased in size and led to a biopsy. And we want to make sure that we're not missing any quickly growing cancers. And so that's why we want to do this 6-month follow-up, be very careful in assessing for changes in size, and then biopsy when we see that. I also want to point out this case when there are multiple bilateral masses, at least we say when there's at least 3 overall and at least 1 in each breast, then we can assess as benign. And we don't need to do a BI-RADS 3. Our second indication for a BI-RADS 3 on ultrasound is a complicated cyst. These should be isolated, complicated cysts with low-level echoes. There's multiple studies showing that these have a low rate of malignancy, greater than 0%, but still less than or equal to 2%. And just like, you know, with the solid masses, if there are multiple bilateral complicated cysts, we can assess those as benign. Like we showed in one example, sometimes these will resolve at the 6-month follow-up. And then, of course, if we don't see the finding anymore, then we no longer need to continue following it. The third indication for BI-RADS 3 on ultrasound are clustered microcysts. We want to make sure we're differentiating a cluster of simple cysts because these can be assessed as a BI-RADS 2. So BI-RADS 3 should be used when their individual cysts are small or deep, or they're not definitely simple. The data supporting BI-RADS 3 for clustered microcysts is definitely less robust than it is for the solid mass or complicated cysts. There's only been a small number of studies specifically evaluating clustered microcysts, but in those small studies, the risk of malignancy is less than or equal to 2%. And so that is considered an appropriate indication for BI-RADS 3. Now in the BI-RADS Atlas, there's a few other indications that are listed based on expert opinion. So the first one is a hyperechoic mass with central hypoechoic to anechoic component, suggestive of fat necrosis. And this, we can do a short-term follow-up to make sure it's changing in a way that is appropriate for fat necrosis or resolving. That's something that we do in clinical practice. And I showed an example of fat necrosis that we gave a BI-RADS 3 to. The other 2 that are listed in BI-RADS 3 are a posterior shadowing seen in 2 projections without a definite mass, or architectural distortion thought to be due to post-surgical scar. These are not findings that in my group that we give a BI-RADS 3 to, and I think that it's likely that in a new BI-RADS that these will no longer be listed. But again, posterior shadowing in 2 projections, if we hope that we'd be able to find a mass associated with that and then would just do a biopsy. If we're able to clarify it's related to a dense calcification, we would want to just call that benign. And similar to in mammography, when we see architectural distortion, we get very worried and we will only not biopsy it if we're sure that it's due to a scar. So we're very careful with looking at post-surgical scars and trying to be confident in either calling the distortion benign because we believe it's related to the scar, or suspicious, and then we want to do a biopsy. But if you're unsure and you think it's probably due to a scar, but aren't 100% certain, then it's possible that a BI-RADS 3 could be a reasonable follow-up plan. I also want to bring up the use of BI-RADS 3 for axillary adenopathy, and this is sort of a timely topic right now. Unilateral adenopathy is rare and typically considered suspicious. However, with the COVID-19 vaccine, we've been seeing a lot of unilateral reactive adenopathy. It can be seen with other vaccines, but it's just a lot more pronounced with the COVID-19 vaccination. And so this has been a really current topic, and there's been a lot of literature and breast imaging related to this to try to figure out what we should do to make sure we're not over biopsying these women, but also not missing malignancies. The Society of Breast Imaging gave a recommendation published in March 2021 that we should be recommending a short-term follow-up 4 to 12 weeks after the second vaccine dose. And if the adenopathy persists, we should do a biopsy. And I showed one example of this where we did not see that adenopathy resolved, and it did turn out to be a malignancy. So we want to make sure we are following these women and letting that adenopathy go away before we assess them as benign, because although we know that the vaccine can cause adenopathy, we also know that cancer can cause adenopathy, and we want to make sure that the reason is just a reactive lymph node and not something else that's going on.
So I'm going to shift gears here and talk about BI-RADS 3 on MRI. This is a tough topic because there's just really not that much data on it. And that's because in order to show that there's between a 0 and 2% chance of malignancy, you really have to have a lot of cases in the study. And we just don't have that many large studies of MRI. But I am going to go over 3 cases that have a combination of evidence and expert opinion to support giving a BI-RADS 3 for these findings. But this is also really an evolving topic. And I'm hopeful that over the next few years that we'll have larger studies coming out on MRI that'll help really clarify what findings we should be giving a BI-RADS 3. But I think we'll also be moving towards trying to give BI-RADS 2 or 4 on MRI as often as we can to really limit the number of times patients have to get repeat MRIs due to the cost and the logistics of having to do that. But with that being said, this is the first finding that there's agreement that fit criteria for a BI-RADS 3, and it is along kind of a theme that we've talked about, and this is that oval circumscribed mass. So I'm starting off by showing a MIP MRI image, and I like looking at these MIP images early on when I'm reading MRIs because it kind of gives a lay of the land, and you can see if anything stands out. And right away, we see this mass in our left breast. When we're looking at the MIP, we don't know if it's upper or lower, but it definitely stands out to us. We like to use the subtraction view to look at breast imaging findings. So here is our first run subtraction. We typically do 3 post-contrast runs in order to calculate kinetics. This is the first of those post-contrast images, and it's subtracted from the pre-contrast image. So the only things that are bright on the subtraction view are because there's contrast in them and they're enhancing. And here is this mass that we saw on the MIP view. It's in the upper inner left breast. It is homogeneously enhancing It has an oval shape and circumscribed margins. And this is very typical, kind of classic features of a fibroadenoma, similar to what we saw on mammogram and ultrasound. This is that oval circumscribed mass category. And again, also on MRI, this could be an appropriate Birads theory. We do need to check a few other things before we can conclude that this should be a Birads 3. So first is we want to look at the T2. We want there to be a T2. We want it to be hyperintense on the T2 series. So here's that finding on the T2, and we see that it is hyperintense on T2. So that is also consistent with what's probably a fibroadenoma. And then we want to look at the kinetics and make sure that the kinetics are reassuring. This is a myth of the kinetics. We see that finding here in the inner left breast is blue. That's type 1 persistent kinetics. That's suggestive of a more benign finding, typical of fibroadenomas. So this does fit criteria for a Birads 3. We could do a 6-month follow-up MRI, but sometimes we'll also recommend that, especially if a finding is over about 8 millimeters in size, we'll recommend that we do a second look ultrasound for the finding. And if we can see the finding on ultrasound, then we can follow it with ultrasound instead of MRI. And that's going to be a lot more comfortable for the patient, a lot less expensive, and it would be just as safe. It's also helpful because we have much larger data to support the use of Birads 3 on ultrasound. So if the finding meets all of those criteria on ultrasound, we feel very comfortable following it. If we don't have an ultrasound correlate, if we can't see the finding on ultrasound, on a second look ultrasound, then we would do a 6-month follow-up MRI to confirm stability. And similar to mammogram and ultrasound, we would want to show stability at 6 months, 12 months, 24 months, with an optional additional study at 36 months to show that this finding is not changing. At any point during that follow-up period, we could change the Birads to a Birads 2 if we feel that it's changed in a way to be clearly benign, or if it's increasing in size or changing in a way that looks more suspicious, we could change to a Birads 4 and do a biopsy. This is a high-risk screening MRI. And again, I like to kind of start by looking at the MIP image to see if anything stands out. And right away on this MIP image, we see this focus in the outer right breast. It sort of stands out. It's a little bit brighter than her other kind of scattered foci around the breast. She does have other enhancing foci throughout both breasts, but this one looks a little bit bigger and a little bit brighter, which stands out to us. Then we can look at the post contrast and find that focus. And here it is in the lower outer right breast anterior depth. It's a dominant focus. The next thing we want to do is similar to our last cases. We want to see if there is a T2 correlate. And in this case, there was not. So here we are sort of matched up on the slices, and we're not seeing anything that's T2 right at that site. This is another finding that is appropriate for a Birads 3, is a dominant or a unique enhancing focus, which does not have a T2 correlate. This actually at our institution was biopsied and was benign. We don't have the kinetics on this case, but there's mixed feelings on whether the kinetics are actually helpful for enhancing foci because they're so small. But as would be expected, if we're seeing persistent kinetics, that would be a reassuring sign. And if we saw wash-up kinetics, that would be more suspicious. And I think with this, if there was suspicious kinetics, I would have a low threshold to do an MRI biopsy instead of following. But like I mentioned before, this is kind of an evolving topic, and the recommendation to follow an enhancing focus without a T2 correlate is really based on expert opinion. The studies have been sort of back and forth on whether there is truly a less than 2% chance of malignancy. But it's clear that there's at least a very low chance of malignancy for this finding. And a 6-month follow-up is a reasonable recommendation. This is a companion case, another MIP projection. This one has some artifact on it. But regardless, this enhancing focus in the posterior left out stands out to us. So we want to look at that subtraction series. And here we see that this enhancing focus in the left breast, which may meet criteria for a BI-RADS 3, but like I've said on those prior cases, it's going to be really important to look to see if there's a T2 correlate. So let's pull up the T2. Here's our T2 here. And here is that finding. On our subtraction view, we see this enhancing focus here. And on the T2, we see a very clear T2 correlate for that finding. This is very reassuring, and there's expert opinion that if a dominant enhancing focus has a T2 correlate, that we can safely assess this finding as being benign and not need to give it a BI-RADS 3. And this can save the patient from having to do unnecessary follow-ups. Our next finding is, here is the MIP reconstruction, and we see this focal area of non-mass enhancement in the outer right breast. And let's look at our subtraction views and find that area. So here it is. So this is a focal area of non-mass enhancement. We want to see if there's a T2 correlate. Here's our T2. And this is at about the same slice, and we don't see a T2 correlate there. So we have focal non-mass enhancement with homogeneous enhancement without a definite T2 correlate. Again, this is also based on predominantly expert opinion, but this is also probably an appropriate indication for a BI-RADS 3, and this is commonly given a BI-RADS 3 assessment. We want to make sure we're differentiating the distribution of the non-mass enhancement. Linear or segmental non-mass enhancement should always be biopsied. If there is areas of non-mass enhancement that have definite T2 correlates, then we can usually assume that those are fibrocystic change or another benign etiology and give it a BI-RADS 2. So when we're talking about non-mass enhancement, BI-RADS 3 should really be reserved for focal areas, or possibly regional, a little bit larger than focal, larger than 2 centimeters, but not segmental or linear. Area of non-mass enhancement that has homogeneous enhancement pattern. And there's been small studies to support this, and a lot of expert opinion to also support the use of BI-RADS 3 in this specific situation. As important it is to talk about the findings that are appropriate to give a BI-RADS 3, I think I also just wanted to point out that we want to be clear when there are findings that are safe to call a BI-RADS 2 and to let that patient go a whole year before additional imaging. And I thought this was a good example because it sort of follows from those kind of post-trauma, post-surgical cases that I showed on mammogram or ultrasound. This is a patient who had had a lumpectomy in her left breast. And we see a very, very classic appearance of fat necrosis. So here is the area of surgery, and we see this fat intensity. It's bright on the T1 non-fat saturated sequence. When we look at the fat saturated sequence, we see that that area that was bright on the non-fat saturated sequence is now dark, confirming that it is fat that makes it up. And on the post-contrast subtraction image, we see a little bit of enhancement sort of around the edge of it, but it's a very thin enhancement. There's nothing mass-like. There's nothing that looks nodular. This is a very typical for post-surgical changes at a lumpectomy site, and this can very safely be given a BI-RADS 2. We don't need to give this a BI-RADS 3.
So while BI-RADS 3 is, a challenging topic overall, I think that MRI is really the hardest topic with BI-RADS 3 because it's a newer field and the data is a lot less robust than on mammogram and ultrasound. I did show a few examples of some cases that there is some data to support the use of BI-RADS 3, and I just want to go over those. So just to start, like I said, this is really an evolving area, and I think we want to be flexible with our use of BI-RADS 3 on MRI and be following the literature, because I think that this is going to be really clarified over the next couple of years. The 5th edition of BI-RADS was published in 2013, and the technology itself has improved since 2013. We're also just doing a lot more breast MRI now than we were in 2013. So this is becoming more and more relevant. But the 2013 Atlas, this is what it lists for reasons to give a BI-RADS 3 on MRI. So first, it includes background parenchymal enhancement. In the Atlas, it says to consider giving a BI-RADS 3 when there's suboptimal timing based on menstrual status or for postmenopausal patients on hormone replacement therapy. They include a dominant focus that is T2 hypointense on baseline MRI, and for masses in oval or round circumscribed mass on a baseline MRI. And then they say that in the Atlas, it says that there's insufficient evidence for non-mass enhancement. So there's emerging data that, this is not in BI-RADS yet. I mean, hopefully when a new BI-RADS comes out, there'll be better guidance, but the more updated literature suggests that we don't need to use BI-RADS 3 for background parenchymal enhancement. There is, with the newer contrast agents, we have not shown that there's large variations in the timing based on menstrual status. And we should really, if we see a diffuse pattern of background parenchymal enhancement, we should be able to assess that as a BI-RADS 2. If there's any areas that stand out and look separate, we should give it a BI-RADS 4 and do a biopsy. But that the space for really doing a short-term follow-up for background parenchymal enhancement has really gone away. The foci and mass, the data has continued to support those two. And I showed examples of these two findings that are reasonable for a BI-RADS 3 assessment. So just to repeat again, we see a dominant focus. So this should be a single focus that stands out compared to the rest of the background parenchymal enhancement. And it should be T2 hypointense, and it should be on a baseline MRI or one with less than 2 years of follow-up. We're going to follow it for 2 years. If it's T2 bright, then we can consider that benign. And if it's a new or increasing enhancing focus, then we want to give it a BI-RADS 4 and biopsy. For masses, as I showed, that kind of similar to mammogram and ultrasound, when there is an oval or round circumscribed mass on a baseline MRI, it's reasonable to give that a BI-RADS 3 and follow. Again, we really want to be careful looking for any changes in size and have a low threshold to change that to a BI-RADS 4 and do a biopsy. And non-mass enhancement continues to be a really challenging topic. There's very limited data on this, but there's some small studies and there's also some expert opinion that suggests that focal regional homogeneous non-mass enhancement without associated T2 hyperintensity may be appropriate for a BI-RADS 3 assessment. So I did show an example of that, but I just want to emphasize that there's not really robust data to support this. And we'll really need to continue following the literature and studying this topic to clarify which cases of non-mass enhancement we can safely give a BI-RADS 3 to and follow rather than biopsy, and which cases we can consider to be just part of the normal background enhancement and give a BI-RADS 2. I want to give some conclusions here and thank everyone for their attention. I know this is I think a topic a lot of people don't like that much, and I'm hoping that going over some really classic imaging examples of BI-RADS 3 on mammogram, ultrasound, and MRI will help to standardize our use of BI-RADS 3 and make sure that we're only using it when it's appropriate. I want to emphasize a few points before we finish. So first is that we only want to be using BI-RADS 3 for specific imaging findings that have evidence that there's a chance of malignancy greater than 0%, but less than or equal to 2%. This is not an intermediate category that we should be using when we're just unsure what to do. It should be to follow a very specific imaging findings. We only want to use BI-RADS 3 after we've done a full diagnostic workup. So we never give BI-RADS 3 directly from a screening exam. And finally, I just want to emphasize that we have really good data for these indications for BI-RADS 3 on mammogram and ultrasound, and we should feel very confident in that it's very safe to use them for the imaging findings that we reviewed today. The data for BI-RADS 3 on MRI is still evolving, and I think this could definitely change in the coming years, and we want to be flexible in our use of it and following the literature so we can make sure that we continue to use BI-RADS 3 in an appropriate fashion on MRI. I want to thank everybody so much for their attention, and I hope that I was able to clarify this challenging topic. Thank you.